Dr. Balaji Krishnamurthy, consultant in pediatric gastroenterology at Al Jalila Children's Specialty Hospital, Dubai. Dr. Balaji graduated from Madras Medical College and Research Institute in Chennai, India. Before moving to UK in 2001, he has been working for many years in field of pediatrics and pediatric gastroenterology in several reputed hospitals, including Children's Hospital at Oxford and Alderhay Children's Hospital in Liverpool. Prior to joining Al Jalila Children's Specialty Hospital, he has worked in Mediclinic Middle East for 5 years. Dr. Balaji will talk about foreign bodies in the wrong place. Dr. Balaji, the floor is yours.
Thank you very much. Thank you very much, Chair, for the kind introduction. I'd like to congratulate Dr. Mikdadi and the team from SKMC for this wonderful meeting. And thank you for giving me the opportunity to talk, to present this to the audience. My talk is about foreign body. It's the bane of our lives. Anytime you get a phone call at midnight, you can be sure that there's a foreign body. Some kid has eaten something or taken something that they shouldn't have. So in this talk, over the next 30 minutes, I'll try and explain to you the various objects that children try to eat and digest, what dangers, what degrees of dangers that can impose on them. When should we or should we not remove them? And if so, when should we remove them? And what are the tools that we can use? What are the gadgets that we use to try and take them out? Right. A few things that children might ingest: pins, paper clips, bulbs. I've seen quite a few things, lipsticks, all sorts of things. The general advice is keep calm and carry on. It's very important to take a detailed history. Find out if the child has actually ingested. So lots of times they come with the direct witnessed foreign body ingestion. The parents see them swallowing. It's too late. By the time they open the mouth, it's gone in. Nothing can be done about it. But many a times you see children presenting with vague, uncertain, unclear symptoms, and you have to then tease out or suspect foreign body. Okay. The important thing is the age of the child. How old is the child? It has prognostic implications and also decision about what do you do if the child has ingested a foreign body. What has the child actually ingested? Is it a coin? Is it a needle? Is it a scarf pin? Is it a battery? Is it magnets? And if so, how many? Is it just one? Are there many? Also important to note, was this a one-time event? Did the child ingest like 7 magnets in one go, or was there extended period of ingestion? Did it take child take 2 at breakfast, 2 at lunch, 2 at dinner? And then you need to be mindful of that as well. When was the ingestion done? If it is witnessed, then you can have a fairly certain time of ingestion. But if it's unwitnessed, then that becomes a very difficult thing to clarify. When did the child last eat? It's very important if there's a foreign body in the stomach and the child has a full meal, it's a nightmare to try and fish out the foreign body from there. Are there any symptoms? Is the child well, running around, doing absolutely fine? Or is the child choking, coughing, fever, abdominal pain, vomiting, respiratory compromise? Will determine what the next course of action should be. Is there any relevant previous history? Has there been any surgeries, tracheal fistula, strictures? Has this child ingested foreign body before? It's very useful to remember, because I had one child who had a coin stuck in the esophagus. I took the coin out, came out and spoke to the parents, and I said, be careful, do this, do this, do this. And I said, has this happened before? And they said, oh, 3 months ago, the child took a magnet, swallowed a magnet, we didn't see it coming out. So I said, okay, fine, let's do it. Abdominal X-ray before you go home. And lo and behold, there's a little, tiny little magnet sitting in the right iliac fossa. We did the laparotomy, there is sat in the appendix, and we had to fish that out as well. So it's very important to get any previous foreign body injection history. Right, the commonest one is a coin, provided it's not stuck in the esophagus. If it's stuck in the esophagus, it has to be taken out. But if it's not stuck in the esophagus, then we can afford to wait. It's not a medical emergency. And if the coin passes, great. If the coin hasn't passed, usually I wait for up to 2 weeks. The guidelines say you can wait for up to a month, but we wait for up to 2 weeks. And if it hasn't passed in 2 weeks, it's unlikely to pass in a month. So we normally go and fish it out. Magnets, very dangerous. They're not toys. These are lethal killing machines for children if ingested. Lithium-ion batteries, again, wonderful piece of equipment for our electronics, but not wonderful piece of equipment for children. Bones, fish bones, chicken bones, things that might have accidentally been swallowed and then get stuck in the esophagus can pose danger to a child. Other things like bulky piece of meat, when children gobble the food very quickly, like explained earlier today by Dr. Rana, children, if they have eosinophilic esophagitis, they can present with food bolus impaction. Sometimes the teeth falls out and they aspirate it and they swallow that as well. Teeth is generally okay as long as it's gone to the stomach and then we just follow it through. So the first question, is it in the esophagus or is it not? How do we differentiate that? If it's in the esophagus, you normally find the coin, the flat surface of the coin facing forward. If it's in the trachea, the flat surface faces sideways. And this is because the vocal cords ensure that the coins goes in transverse rather than flat surface facing forward. And again, if you do a lateral X-ray, you can see that there's an air shadow in the front and then the coin stuck in the back. So that also clarifies whether the coin is in the esophagus or trachea. Next question, is it a coin or is it a battery? They look very similar in terms of size. So if you look carefully with the battery, you can see a double halo. You see two circles, whereas with the coin, it's a pretty uniform radiopacity. And also, of course, the history will tell you. If the parents say that my child was playing with a battery and now I can't find the battery anymore. So I'll present a case which I dealt with personally within a week of coming to UAE. So I've seen foreign bodies in the UK when I was there for about 16, 17 years, but not that often. We see them once in a while and we go in and we fish it out. But then here, it seems like that's an epidemic out here. So this child, 15-month-old, presented to the emergency with a history of persistent cough. And as they do, they've been to various GPs, they've been given antibiotics until someone decided to do a chest X-ray, and lo and behold, we found this. So this child came in. Again, there was history. If you go through the history carefully, there is history that the child was eating less and less, was coughing more when the child was drinking. So there were some soft, subtle clues there in the history if one took the time to take it properly. So this was the X-ray we saw. On the lateral, you can see that it's stuck in the proximal esophagus. Contrast study, this is done after post-removal. You can see there's a leakage there from the esophagus going into the trachea. A CT scan, again done post-endoscopy, that's the nasogastric tube. And that's the tracheal fistula. So basically, the battery had burnt a hole between the esophagus and the trachea, and therefore this child was coughing. Had a stomy course. We put a nasogastric tube initially, but the child was vomiting, then we put a gastrostomy, kept the child on TPN for some time, hoping that it will heal and it will close spontaneously, which didn't happen. Went for surgical closure. Again, the child was refistulized. So the tracheal fistula had underwent refistulization because of the poor, unhealthy tissue surrounding it. We then went in and injected histocryl glue, which is like a super glue that you can inject. Usually it's used for portal vein sclerosing. And that resulted in closure of fistula. So that was my first venture in foreign bodies in this country. Button battery, there seems to be like a little outbreak of children eating button batteries as food. And you can see there's a steady rise over the last 10 years. This is the data reported to National Battery Ingestion Hotline. You can see there's a steady rise of battery ingestion. The bottom part of the chart, the blue bars, are the fatalities. So it's not a simple thing. It does result in death. And it is something that we have to be very, very careful about. How do they cause problems? A spent battery is still dangerous. They still have enough residual charge to cause problems. It's not electrical or thermal injury that causes the problem. It's actually hydrolysis, generation of hydroxide radicals, which then goes and causes an alkaline damage. So it's caustic injury caused by the alkaline radicals generated. And this results in a rise of pH from 7 to 13 within a space of 30 minutes. In vitro exposure of battery to the piece of meat here, you can see the damage within 50 minutes and then 2 hours, resulting in complete burning and creating a hole. Necrosis can occur as fast as within 15 minutes. So if a child presents to the emergency having ingested a battery and if the battery is stuck in the esophagus, the first thing we do is tell them to start giving them honey. I'll come to that as well, because the honey helps in coating the battery and also has slight acidity, so it reduces, it decreases the pH. And Also important to remember that once the battery is taken out, it's not the end of story. The damage can still persist, the damage can still progress. So these children, we have to be very, very careful in watching over them. There have been reports of death almost 3 weeks down the line after removal of battery due to aortoesophageal fistula, aortoventricular fistula. The commonest complications of battery ingestion is tracheostomy fistula. Almost half of the children end up with tracheostomy fistula. Some of them have perforation, some of them have vocal cord paralysis. The most dangerous, the one we worry about, is the aortoventricular fistula, because it's right next to the arch of aorta. And if the negative pole is facing forward, it's where the negative pole is. It's also important when we take it out to see where the negative pole is. Is it facing forward? Is it facing to the back? If it's facing forward, then the injury can actually progress anteriorly and erode into the aorta, resulting in exsanguination and death. And we unfortunately had one episode a few months ago in Jalila. An important case report published by our colleagues in Saudi Arabia, a 2-year-old child with aortoesophageal fistula who we managed to save by having good combination with the cardiovascular surgery, and they managed to get a vascular plug device. So we have actually changed our practice in our center, that if there is button battery ingestion and the child comes with battery in the esophagus, we automatically initiate the call to the cardiothoracic surgeon. We don't wait for them to come in, but we initiate the call. But if there is bleeding, then the child is shifted to the cath lab. We wait for the whole team, the cardiovascular team, ECMO team to arrive. And potentially, I mean, we haven't had it yet, but potentially catheterize the femoral, get femoral access, have catheter ready in case the child exsanguinates, then we can at least plug the hole, or at least try to plug the hole. So we can do the best we can for this. Because quite often what you find is the battery is eroded in the esophagus, but into the aorta, but it's plugging the hole. And if you take the battery out, it can exsanguinate. So we need to be prepared for that eventuality. So if there's bleeding, get everyone on board. Get the cardiothoracic surgeon and the ECMO team on board before you do anything. This is a pathway published in 2015. There is a more current pathway published recently in JPGM through the ESPGHAN committee. It's essentially if the battery is in the esophagus, needs immediate removal. If the battery has gone beyond the esophagus, then there are a few other possibilities. It depends on the size of the battery, depends on the age of the battery, depends on symptoms, whether the child is symptomatic or not symptomatic. If the child is symptomatic, I would go in just to make sure, because the battery could have been stuck in the esophagus for 15, 20 minutes, half an hour, and then gone down to the stomach. So we need to go in and make sure that there is no esophageal damage there, and also try and fish the battery out if possible. But if the child is asymptomatic and the battery is in the stomach, then you don't have to rush in. You can take your time, wait and see if the battery passes through. But if it's a younger child, I wouldn't normally necessarily wait. I'd probably just go in the next day. The child comes in at night, I wouldn't go and do it at night, but maybe the next day I would go in and take the battery out. This is the pathway that we have in our institution in Al Jalila. The important strategies, what to do if you get a child that comes to the emergency with the battery stuck in the esophagus. First of all, I think everyone needs to be aware what are the centers available that provide 24/7 service that will offer battery removal for pediatrics. Okay. Second, preferably in a center that also has cardiothoracic surgery available. So, and from the parent side or from the other hospital side, what they can do is they can start giving honey to this child, provided the child is over a year old. If it's 12 months or older, 10 mils of honey every 10 minutes, and hopefully they'll get to the next hospital within an hour. If you don't have honey, sucralfate is the other thing you can try. Yep. They have tried other things like lemon juice and other things as well, but honey and sucralfate are the best in terms of reducing the damage, coating the battery, and also reducing the pH. So they actually minimize the alkalinization of the mucosa. And once we remove the battery, we also, it's in our protocol that we also drain or irrigate the mucosa with acetic acid, with 0.25% sterile acetic acid, 50 to 100 mils, to the displeasure of the anesthetist, but we do instill a lot of acetic acid to make sure that we neutralize and minimize the chance of ongoing damage after removal of battery. Okay. There are plenty of advisories and caution notes available online, and this is one of them from the ESPGHAN. And we should try and ensure that these materials or this information is disseminated widely, schools, nurseries, kids clubs, TVs, radios, newspapers, etc., just to make people aware. The materials online as well. I think Jalila, we had a partnership with Duracell, and we've come out with battery advice as well. what's happening in the world, in the market, people are now realizing the battery companies are taking it more seriously now. So they have instilled some safe measures, scissors to open the packaging. So if some electronic devices, if you open them up, you have 3-4 batteries and they all fall out at the same time, and then some roll under the floor and you lose them. So now they're trying to make sure that there's an individual compartment for each battery so that you open one by one and you take them out. There's also advice that if you have spent battery, old battery, cover them in tape and discard them in the bin. Also, one company, interestingly, has come out with a bitter coating of the batteries to make sure the child puts it in the mouth, they'll spit it out. Okay, in a nutshell, battery in the esophagus is dangerous and needs immediate removal. Evidence of fistula, keep the child, if there's fistula, then keep the child faster, do a CT scan to make sure that there is no damage or there's no extension of damage to the aorta. If there's bleeding, get cardiothoracic surgery on board. Battery in the stomach, if it's less than 5 years and if it's the big battery with more than 20mm battery, then take the battery out as soon as possible. If the child is more than 5 years old, or if the battery is less than 20mm, then it's not so much of a danger. You can actually afford to wait and watch. Do an X-ray in 14 days. If the battery is still in the stomach, then fish it out. Okay. Greatest risk, younger than 5, more than 20mm, multiple batteries, or magnet co-ingestion, fully charged battery. Right, moving on. The next one is magnet ingestion. Again, wonderful toys as they were initially promoted. Colorful, very colorful. You can make lots of wonderful shapes. These are neodymium rare earth magnets, extremely strong magnets. I mean, if you've had some of them, if you try and pull them out, you cannot pull them apart. It's very, very strong. They're 5 times more stronger than your conventional magnets. Usually they come packaged like this, big bundles, so very difficult for the parents to keep track. A few roll down and they go under the carpet or they go under the bed, and then the child who's crawling finds them and sees the shiny little things and puts them in the mouth. There's been a mandatory recall in the US. There's been a voluntary recall in Europe. And recently we've had a ban of magnetic toys in the UAE. Thanks to the efforts of Dr. Migdadi, Dr. Christos, Dr. Nafair, and Dr. Amit. So we have got an official ban, but we can still find these toys in the shops. So if you do go shopping and if you find these toys, please let the shopkeepers know that they're actually breaking the law. Okay. So if a child comes to you with magnetic ingestion, get the history, get an X-ray, always get 2 views. Because sometimes the magnets may be stuck and there may be one behind another. So if you get an AP view, you might just see one magnet. But if you take a lateral view, you can actually see dual magnets. So if it's multiple magnets, it's dangerous. Single magnets are not so much of a problem. Okay. If it's a single magnet, you can deal with it like any other foreign body ingestion. You can just say, educate the parents, make sure they don't have any metallic belts or avoid anything else. Also make sure that the child does not go home and have something else metallic, which may make it worse. If there's multiple magnet ingestion and if it's in the stomach, try and fish it out. But if the child has symptoms like abdominal pain or peritonitic, then we do need to get surgeons on board. There's a very, very high chance that this child ends up needing surgery. With multiple magnet ingestions, almost 75% of the children end up with surgery because of multiple perforations. There's an image of a case that we dealt with recently. Came in with a ring in the stomach. And when we scoped, we found this. You can see 4. There's about 9. And if you can see 4, and the rest seem to be buried in the mucosa. I had a similar one a few years ago, but that was in a line, and I could see 3 and I couldn't see the rest. So I got the surgeon on board, they did a laparotomy, and we found that the magnets had actually eroded submucosally in the stomach, but had not actually perforated. So with that experience, I pulled this out with 2 holes in the stomach mucosa. We clipped it, kept the child in trio, did an X-ray next day with endoscopy, we blow in a lot of air. So if there's a leakage, I would expect to see some air leak. There wasn't any free air. We did a contrast study, there was no leak. So we allowed the child to start eating and drinking, and this child went home. Thankfully, he didn't have any perforation, it's just a submucosal perforation. But that's not usually the case. What you see is here the magnets are stuck together, but from different loops of the bowel, and when you pull them out, you can see the holes there. And quite commonly, you find not 1 or 2 perforations, maybe 3, 4, 5 perforations, ending up in resection of the bowel. As mentioned, UAE has now banned magnetic toys. Okay, moving on. The next one, not so common, but can be quite a challenge. This is super absorbent polymers. They have been marketed as children's toys, as water balls. I don't know who comes up with these ideas. They are extremely absorbent polymers, and they're used usually in diapers and in hygiene products. They can also use in agriculture and gardening where you put them in the flower pots and they hold on to the moisture and they keep the soil wet for a longer period of time. And the interesting thing about these things is initially, when they're dry or dehydrated, they're very, very small, tiny little things. So you swallow them, they go through easily, it does not cause obstruction, it passes through the stomach, it goes into the intestine, and slowly they start imbibing water. And when they imbibe water, you can see the difference. The same ball has become almost 10 times the size. And they then end up causing obstruction. The tricky bit with this is they're radiolucent, so X-rays will not show them. So if the child presents with obstruction, invariably they'll end up needing exploratory nephrotomy. However, if the child comes early on after ingestion, we can try, maybe we can do an endoscopic evaluation to see if it's in the stomach and try and take it out if it's still there, but that's more often than not. Sharp objects. Again, I've seen children, quite old, 10, 12 girls with scarf pins in the mouth, tying the scarves, and they open them out and the pin goes in.
2 minutes, please.
Thankfully, the blunt end is proximal for them, but the difficulty for us is that the sharp end is facing the scope. So when you try to pull them out, it becomes very, very tricky. Remember, the advancing points puncture, trailing points do not. And if they can puncture the skin, they can puncture the gut. So that's my clue. So if someone contacts you and says, oh, my child swallowed, it's bitten off a fork or bitten off a piece of the spoon, if it's plastic, they don't usually cut your skin, so it's okay. It's very unlikely that they will cut the gut as well. Okay. Commonest place is ileocecal region. If the sharp object has gone beyond the stomach, it cannot be endoscopically retrieved, then we have to monitor with serial X-rays. If they appear to be moving, then we just keep them on. But if they're not moving and are stuck there for 2 or 3 days, or if the child is symptomatic, then the child will need surgery and removal of that sharp object. X-rays are good for metallic objects, but for toothpicks, for wood, or for plastic bits, they can be a nightmare because they're radiolucent. So if the sharp end, if it's stuck in the esophagus and the sharp end is facing the scope, the best, safest thing to do is push it down into the stomach, flip it around, and get it and pull it up. So that the sharp end is actually pointing downwards and not upwards. So what are the tools we use? So if there's food bolus obstruction, you can use a basket or net to try and get it and block, but it can be quite tricky because they come in pieces, bits and pieces. Sometimes, if possible, if there's no obstruction, you can push the food bolus down into the stomach and leave it there, and that will sort itself out. You can use forceps, either rubber-tipped forceps or tooth forceps for coins and batteries. Coins are easier because they have a ridge, so when you grab hold of them, you can actually pull them out. Batteries are a nightmare because there is no ridge, and in fact, there's a downward indentation, so when you actually hold on to them, they keep slipping. If that is the case, then there is a trick we can do. We can actually, if there's no esophageal damage, you can actually pass a Foley's catheter beyond the battery, blow the balloon up, and then try to take the battery out. For sharp objects, you can either use an overtube to coat the esophagus when you pull the battery out, or in smaller children, you can use like a hood to get the sharp object safely within the hood before you pull them up the esophagus. Other things that we can use are blunt tooth forceps and snares. Right. If there's esophageal food impaction, remember, consider other things. Don't just go and sort out the problem, but also look for other problems. Is there a stricture? Is there eosinophilic esophagitis? So it may be worthwhile doing some biopsies as well. Push technique versus pull technique. If you can't pull it out, try and push the food bolus into the stomach and leave it there. Right. Take home points. Button batteries are dangerous. If it's under 5 or more than 20 millimeters, they're extremely dangerous and we have to be dealt with immediately. Batteries, if there are multiple battery ingestions, again, can be dangerous and becomes a medical emergency. Superabsorbent polymers are not toys. Sharp objects, advancing points puncture, trailing points do not. And if it can puncture your skin, it can puncture the gut. Surgery if it hasn't progressed in 3 days. Thank you.